Yes, great question. And you know what? When I just started the UCARE, being in the UCARE network around 2017, then I was thinking we have a lot of female patients, but there were really very less information on how these patients handle urticaria during pregnancy. There were no reports, no studies, and this really, I was so curious about what's happening to these patients during pregnancy and how we should treat them better.
Welcome to All Things Urticaria, the podcast where we dive deep into the world of hives, angioedema, and everything in between. Normally, you're in the hands of Professor Torsten Zuberbier, but today I'm thrilled to be stepping in as co-host, and we have a very special episode lined up for you. My name is Sophia Neisinger, and I am a physician also at the UCARE in Berlin, Germany. And my focus is digital health, so I like to build digital tools for our urticaria patients. And today, joining me is someone whose energy lights up every room. And I'm very happy to have here Professor Emek Kocatürk. Welcome, Emek, to this episode.
Sophia, I'm so glad to be here and I'm so happy that you are hosting this episode. So it's so nice to be with you and maybe discussing some female things that we can discuss better.
That is right. Today we're talking about a topic that is very important. We talk about not only female patients with urticaria, but also pregnancy and urticaria. And Emek, if we take a look at the numbers, well, most chronic urticaria patients are female. Do you know why?
Yes. I think it's a great starting point. And yeah, it's a female predominant disease. When we look at mainly all the populations, almost all the populations, it's always 70% female patients in the CSU population. So it's apparently a female predominant disease. The only exception is the cholinergic urticaria, where we see male patients, usually young male patients, but the other inducible urticarias and chronic spontaneous urticaria, they are all female dominant.
That is very interesting. So cholinergic urticaria has a special part, right? Different from CSU.
Yes.
What can you say? Is it like a special, I don't know, phenotype? Does being female affect CSU? Do they have, is the urticaria worse than the one that male patients have?
Yes, very great question. Yes. First of all, why is it a female disease? I think maybe it's, all the autoimmune diseases are more common in female patients. And this is another point that also supports that chronic urticaria, chronic spontaneous, and also some of the inducible urticarias are autoimmune, directed with autoimmune mechanisms because of the female predominance. Maybe we can speculate on that. Maybe X chromosome is maybe some linked genes that linked with X chromosome make them more predisposed to autoimmune diseases and also chronic spontaneous urticaria. And also the immune system is functioning differently in females. For example, females produce more autoantibodies. That's why they have more autoimmune diseases, and also toll-like receptors are working much more in female patients. So, it was good to have this immunity during COVID times because the females did better during COVID times. And also estrogen can also be determinant because it's a pro-inflammatory hormone which predisposes females to autoimmune diseases. So I think these can be the major things that contribute to female dominancy in CSU. And the second question you asked, is it different in females? So for this, we did an analysis from Q registry, and we saw that it's really worse in female patients. They have more burdening chronic spontaneous urticaria. They are suffering more. Where do we know that? Because they have more angioedema, they have more systemic symptoms. they have more quality of life impairment, more sleep disturbances, and interestingly, their UCT scores, that means the control of urticaria, were less with every medication. For example, standard doses of antihistamines, high doses, omalizumab, cyclosporin, the UCT scores were all lower for female patients when we compare to the response rates to male patients. So suffer more, yes. And another thing was they had more comorbidities. What kind of comorbidities? Of course, we can guess that autoimmune comorbidities, but also asthma, thyroid disease, gastrointestinal disease, and depression were more common in female patients. Of course, this increases the suffering more in female
Yeah,
patients.
absolutely. Wow, Emek. We really have the expert here, and I see we really know a lot about it, but it's not that so many, I think, also physicians know about this kind of, special phenotype that that female patients with chronic urticaria maybe even suffer more than our male patients. So very, very interesting. And for those listening who do not know, so CURE is our urticaria registry. Yeah. If you want to be part, just Google CURE. And something new is also, we now also have an angioedema registry called CARE. If you want to take part here, do a little bit of research, feel free to write us, and both have very nice web pages where you get more information on it. So very interesting. We have female patients. They maybe do not respond that well to medication if you compare it to male. So more female patients, Emek, means we have more pregnant patients. Is there something that you can tell us? Does something happen with the urticaria during pregnancy?
Yes, great question. And you know what? When I just started the UCARE, being in the UCARE network around 2017, then I was thinking we have a lot of female patients, but there were really very less information on how these patients handle urticaria during pregnancy. There were no reports, no studies, and this really, I was so curious about what's happening to these patients during pregnancy and how we should treat them better. Because, it's also during the reproductive period where we see CSU between 25 and 45, the most common age. So it's interesting that we didn't know much. And then I decided to make a UCARE project. We are doing a lot of UCARE projects and we are learning a lot with our colleagues. They are participating into our projects and we are creating a lot of information for chronic urticaria management. So we did the PREG-CU study and collected around 300 chronic spontaneous urticaria patients who experienced pregnancy, and we asked them questions about how their urticaria progressed during pregnancy. And in the end, we learned that half of the patients are getting better during pregnancy. I think it's a very good news for CSU patients who are planning to have pregnancy. Our
Absolutely.
patients are always very scared to be pregnant because they don't know if it will get worse or what treatments can they use. So it's a problem for many patients. And learning that half of the patients are getting better during pregnancy, I think this encouraged me and also I encourage my patients to get
Yeah,
pregnant, not to be scared.
absolutely.
Useful information.
Yeah, absolutely. I get this question a lot, and it's so important, yeah, to encourage your patients that they're not afraid of getting pregnant. And this is also very important because patients, when they find a good medication that they are on, and then they're asking me, but now I want to get pregnant, do I have to stop with this medication? Yeah. What do you tell them, Amik? Do they have to stop, or does it depend on the kind of treatment they are on?
Yes, yes, very, very good question. Very nice practical question we need to answer. So, of course, not all the patients got better during pregnancy, and one third got worse. And so it was important that we need to treat these patients, as you say. They always want to know. So, and we have to deal with these exacerbations also. And try not to let the patients be without treatment because we can have exacerbations, and the exacerbations were associated with worse outcomes of pregnancy. So it's very important to keep urticaria under control during pregnancy. That's why we need to give treatment to our patients, and so we can follow the EIK Urticaria guideline, International Urticaria guideline, which suggests that we can use the same algorithm in pregnant patients, but of course, discussing with the patients what we know and what we saw in our study, because in the PREG-CU study, we also checked the treatment effects of the patients in the outcomes of pregnancy, and we saw that having a treatment didn't affect the outcomes of pregnancy. They didn't lead to worse outcomes such as anomalies or preterm rate. So they were not associated with worse outcomes, and this is a very nice news. So what shall we do when standard dose of antihistamines usually is safe, and there is a huge meta-analysis that included 50,000 patients who used antihistamines during the first trimester, and they didn't find any worse outcomes with these patients. So we can use the second generation antihistamines, but some of them are more safer, I can say. Which ones are safer? Cetirizine, levocetirizine, desloratadine, and loratadine are the safest ones. Also, fexofenadine can be used, and bilastine can also be used, but the most safe ones are cetirizine and loratadine. So we can use these during pregnancy. But when it comes to updosing, we don't have a lot of information about updosing antihistamines during pregnancy. I think updosing up to two-folds, which we also saw in the PREG-CU study. The physicians also updosed to two-folds, but there were no patients that were treated with four-fold antihistamines. I think less patients require higher doses, but if they require higher doses, I think going with omalizumab makes more sense in these patients, because omalizumab doesn't cross placenta till the 26th week. So we can give it at the maybe during the second trimester and be safe in the third trimester, because it can cross the placenta after the third trimester, and it is considered as pregnancy category B according to FDA categories, pregnancy categories. It's a safe treatment, and there is a expect study that included asthma patients treated with omalizumab, and there were no worse outcomes when they compared to asthma patients without using omalizumab during pregnancy. So it's, but for CSU, it was not a study for CSU, but we have a lot of case series reported for omalizumab and CSU, and all report successful pregnancy outcomes in CSU patients treated with omalizumab. So I think it's
Very good.
also a safe treat.
So treat pregnant patients if they suffer from the urticaria for sure. I'm sure the stress is not good for the baby if a patient suffers without treatment. So I think this is a very important point for all colleagues out there to not be afraid. They can take a look into your publication, Emek, right, if they want to check for some further information. And for the colleagues in Germany, we have this very good webpage actually that is sponsored by the Charité University Hospital and the Ministry of Health, called embryotox.de, if they want to take a look over there. So treating our pregnant patients, helping them, I think is very important. And now with the data and the case reports, we see it can be safe. You just have to sometimes adjust the treatment a little bit. Very interesting. Thanks, Emek, for this. Okay, so we treated our pregnant patient during pregnancy, and then she wants to breastfeed her baby. What do
Yeah.
we tell her then?
Yes, of course. So if they are using these standard dose antihistamines, they can continue with that. The antihistamines go to breast milk in very less amounts. So even updosing antihistamines is safer during lactation than during pregnancy. So it's possible to updose antihistamines during lactation. And omalizumab cannot really cross to the milk, because it's a very big molecule, and also it's demolished by the gastrointestinal tract of the baby. So it's safe to use omalizumab during pregnancy also. So it's good to have our patients under control. We have a lot of patients that have exacerbations of their urticaria during lactation, not only because of hormones but also because of stress, because this postpartum period is a very stressful period
Absolutely.
for female patients. So I think it's good to keep urticaria under control, to make them have happy postpartum period with their babies. It's so
Most
important.
important, yeah. Make them happy, and patient always most important part. Yeah, and shared decision making, of course, also important here. So also that the woman feels safe in whatever we decide to treat her with. One
Hmm.
last very practical question. So we have our pregnant woman, Emek, and she's on omalizumab, the end of her pregnancy. And normally, when they self-inject themselves, they do it on the abdomen, right? But if they're pregnant, you would probably do you choose another, like upper thigh, to do the injection, or arm, maybe if the partner does it?
Yes, yes, good point. I think that makes sense, even though there is no mention in anywhere about this. But I think this is a very practical point. Yes, they can do it in other parts on their thighs and arms, as you said, as you mentioned. Thanks for mentioning this,
Yeah,
Sophia.
maybe just a little bit. It feels better for the woman if it not
Yes,
directly
yes, I
in the
agree.
belly.
Good point. Yeah,
Psychological wise.
yeah, yeah, sure.
Perfect. Thanks a lot, Emek. This is very, very interesting. And I think with this, we got a perfect overview of pregnancy and urticaria. We know quite a lot already, especially thanks to your big study, and important to treat our pregnant patients. If anyone is not sure about treating them, they can always reach out. I think also to you. You're open to questions, and do not be afraid here. We're happy to help. So to close up this session, Emek, my last question that I always like to ask is there any fun fact about you?
Oh my God, what kind of fun fact can this be?
So maybe while you're thinking, I think one important thing to tell everyone, it's not that Emek just joined this podcast in a normal outfit. She's dressed up in this beautiful outfit. I will share a picture on LinkedIn. So this is how you will see Emek on every conference. So yeah, very,
So
very
I just
beautiful.
wanted to be a bit female-ish.
Love it, love it. Female support.
Okay.
Okay, but back
So
to your
maybe I,
fun fact.
I can tell that I was playing guitar and singing when I was in university and also when I was a resident. But yeah, then I married and had a baby. And yeah, I was so busy that I had to quit doing this stuff. Maybe I will do it.
Okay. So next office party, I will have this in mind, Emek, that you're the singer.
I
Very
can't do
nice.
it anymore, but maybe I have to study. And yeah, after learning German, my second thing is to start singing and playing guitar again.
Perfect. Thanks a lot, Emek, for joining us today, Professor Emek Kocatürk, on this episode of All Things Urticaria. Join us for the next episode, and we're looking forward to it. Thank you.
Thanks so much, Sophia. It was so nice being your guest. Thanks for having me.